Perfect. Thank you. And hello everyone, and welcome to the third in our series of our Improving Healthcare with Simulation workshops. This month, delighted that we have the topic of simulation for health economic analysis. Today, more than ever, governments and health providers are under extreme pressure to reduce costs while maintaining patient quality of life, and accuracy of information presented to them is really critical for acceptance. And what we're looking to do in this workshop is look at the use of discrete event simulation for health economic investigations that are really conducive for decision making by payers and providers. And delighted that we can be joined today by Ron Shannon from Global Health Economic Projects. If you could just skip the slide, please, Ron. And Ron is, as I said, President of Global Health Economic Projects, and Ron is a pretty esteemed career, I have to say, starting with a master's degree in public health, majoring in epidemiology and health economics, and has over 10 years experience in health economics and epidemiology and clinical outcomes, research and value-based market development. Ron's done some work with Simulate, but also has a lot of other interesting projects which he'll take us through today and look at the use of simulation and the advantages of it for health economics. And also delighted to be joined today by Fiona Lindsay, who's from a very own Simulate, a healthcare simulation specialist, and who has been specialising in working with Ron on some projects through health economics, but also she looks at emergency departments, winter pressures, bed modelling, and really whole system modelling with simulation. So before we get started, if you could skip on to the next slide, Ron. Just a few housekeeping points. You are all muted just now through the audio, but if you do want to ask any questions, then please use the chat panel, which is on the collapsible screen on your right-hand side. If you want to type in some questions there, then we'll get to them throughout. And if not, then we'll be able to get in touch with you after the broadcast. And finally, just to say that a recording will be made available at simulate.com/improving_healthcare. And that's if you miss any points or any slides that come through, and we will be sending that slide deck through to you after the presentation also. Okay, so it gives me pleasure to hand over to Ron, first off, who's going to take us through to this month's workshop. Thanks, Ron.
Great, thank you, Steve. Thank you for the introduction. I would like to say good morning or good afternoon or good evening to the participants in this seminar. It appears that we have individuals from around the world, which is fantastic. As most of you probably know that are joining this seminar, that there are cost constraints and health economic concerns, not just locally in your particular region, but on a global scale. And many countries are utilizing various health economic techniques to address decisions and policy making, if you will, in regards to whether or not they use a particular therapeutic intervention or not. Part of that process is health economic models. That the process of health economic modeling is critical, especially in a world where there can be limited data coming from clinical trials or observational studies where simulation and models fill that gap. So what I'm going to do today is just give you a very brief on health economic modeling. Some of the formats that have been used are being used. I'm going to talk a little bit about discrete event simulation and the advantages of discrete event simulation. Then I'm going to show you an example, or rather it's not an example, it's a working copy of a model that is created via Simulate software that I use in decision making with providers and payers. And then we'll open it up for questions, and we have references attached to this presentation. I am sure that Steve and Simulate will be dispensing this presentation and all the references to all of you so that you can follow up and read further into health economic modeling. So, to start, hopefully most of you are aware of ISFOR, which is the International Society for Pharmacoeconomics and Outcomes Research. It is an organization that's been around for quite a few years, and they have produced various guidelines on outcomes research, on modeling in particular that we're talking about today. And one phrase that I like that was actually coined by Dr. Weinstein at Harvard University School of Public Health is that models really are an analytic methodology that accounts for events over time and across populations. It's based on data drawn from primary meaning clinical studies, observational studies, meta-analysis, and or secondary sources, which could be randomized controlled trials that have been published in various other types of data. The purpose of modeling is to estimate the effects of an intervention on valued health consequences and cost. That word value is a coined term today that is on everyone's minds. And as I'm talking from the United States, that term value in value-based purchasing, value-based decisions are a hot topic in the United States and around the world. So models will help us to determine the cost and consequences of particular therapeutic interventions. The real aim of health economic modeling, as I just mentioned briefly, is to include in those models the therapy. We need to take information from clinical studies, from secondary sources. We need to take that information, like the efficacy of a drug or efficacy of a procedure that's implemented into an emergency room, if you will, to reduce infectious disease. Utilizing epidemiology, which includes risks, probabilities of infection, probabilities of healing, probabilities of death. Side effects are also very important. Life expectancy and quality of life. Quality of life, as many of you know, are a requirement for pharmaceuticals today with organizations like NICE and ICWG and SMC, where we can interject utility values from quality of life into these models, ultimately leading to a quality adjusted life year. And at the bottom, probably, if not the most important, it does have the greatest importance is the cost that are associated with the performance of therapeutic interventions or the performance of individuals in the healthcare world today. So all of this information populated into a model leads to decisions, whether to treat or not to treat, whether to use a particular drug or not, whether to add resources to a healthcare institution that would prevent a disease. All of this information compiled from various sources can be loaded into models to reflect that situation that or the objectives that you're looking at. So, two aspects of model-based economic evaluation necessary to produce the mean estimate of cost effectiveness. Cost effectiveness has many terms. Cost is obvious. Cost could be direct or indirect cost, intangible cost. Effectiveness, we may be looking at death, we're looking at survival, we're looking at healing, we're looking at pain reduction, we're looking at disability. Those are typical endpoints in many modeling exercises. And then for a given set of parameters, the parameters are all the biological parameters that are inherent within that. It could be hospitalization as another parameter and so on. The next very important topic in modeling is sensitivity analysis. As most models work with limited data and limited information, sensitivity analysis allows us to vary the variables that are included into models, showing us various thresholds, if you will, of cost effectiveness. Sensitivity analysis can be something like cost effectiveness susceptibility curves and various things like that. Very important in modeling, and the ease of a model to generate that type of analysis is extremely important. And I must also say the accuracy of models in real-world applications or real-world healthcare is of extreme importance today, as many of the payers and the providers that I speak to, which are literally around the world, are concerned how that therapeutic intervention or that process will fit into their everyday life, or do they have budgets to pay for some of these interventions. So all of this within the model hierarchy is very important. So one model that has been used, or model type that has been used quite a bit, it's still used today, is the decision tree, where start out with a patient or a population, and they have different options of care. They can be treated, or it could be a wait and see or a no treat, possibly in the disease area of cancer, whether you give chemotherapy or you do not, or you wait over time. You take a look at the response, no response. The P1 is a probability. What is the probability that if you treat that you will get a response? If the probability of no response, and so on. Branches and outcome endpoints with the inverted triangle include information which are the consequences: expected response, life expectancy, quality adjusted life year in the form of a utility, for example, and a cost. Limitations with the basic decision tree can be quite large. One major limitation behind this is timing. It is very difficult to build decision trees to represent the continuous nature of disease over time. This has an input, making it more of a endpoint. It's not finite. It's a definite endpoint to this, only allowing you to take a look at those different aspects of therapeutic intervention within a very limited period of time. I'm not saying that decision trees should not be used. They're very limited, and they should be used for appropriate applications for decisions in short periods of time. The other thing about decision trees, and I've built many of them over the course of my career, is that they can become very unruly and they can become very large. So large that it's very difficult to assess, to go back and take a look at responses and outcomes and build them. It's even more difficult for someone else other than yourself that build these decision trees to make any sense out of them. So they can be very difficult to use, especially with chronic disease or recurrent disease, limited to short-term like surgical response and so on. The next aspect of models are cohort or individual state transition models. Many of you may be familiar with these, but a cohort model, which is a representation, a diagram on the left, basically puts individuals or cohorts starting out in a health state or a Markov state, and I'll talk briefly about Markov in a moment. And from that initial state, they, based on transition probabilities in time, say after a year, those individuals will transition to different health states based on the time, based on probabilities. Within these health states, there are credits. The credits can be utility values, the credits can be cost, credits can be other factors that you put into that state that that individual or cohort of individuals, if you will experience while they're in that state. The dead state is what it says, is that once they reach the dead state, then that's the end point for that particular part of the cohort. Looking at the individual-based state transition model, this is a Monte Carlo simulation model where we have individuals that begin in the well state and they will transfer from well to disease or dead based on a random number generator at the beginning, also included with transition probabilities. So there's more randomness built into this type of a model. Again, some issues behind these types of models. And by the way, these type of models have been used a great deal for policy decision making over time. They still are used. But again, the limitations on some of these relate to mutual exclusivity. Even though they represent recurrent disease, it's very difficult for them to represent a natural process of patients going through the disease processes, because once they reach a health state, that health state is discrete. It ends. There's no memory of previous health states beyond the last cycle that they go through, making it difficult to represent the natural progression of disease, and therefore applying cost and applying utilities and applying various information as credits into those health states. This is just, again, a representation of hepatitis B model. This is published. This is not a model that I had done. I like the diagram, and the publication was quite nice. And here again, you can see that in the initial stage, cycle 0, if you will, the cohorts, the individuals will start, and then over time they will transfer to different cycles or health states based on probabilities. And the credits that usually are included in these health states are utility value and cost. So each time an individual or a cohort arrives in that state, those credits are added to them, leading to a total cost over time. Typically, these type of diseases are ran over a lifetime period. So individuals that die, they go out of the model, and then anyone that is remaining, they continue to add credits, leading to a quality-adjusted life year. And this just is another example based on the same model, the hepatitis B model, where patients are randomized, and then based on that randomization originally and the transition probabilities will go to other health states in the model. The main reason for this slide is that all of these individuals, including decision trees, Markov models, Monte Carlo simulation, must be independent. They must be mutually exclusive in terms of the different therapies. There is no interaction within these models. It's not allowed within the Markov process or the Monte Carlo process. But getting into discrete event simulation, what we call event-based models, they are key models that are now being used a great deal to represent interaction. And what I really mean by the interaction is a very naturalistic way that clinical pathways and interventions can be represented. Many of you that may be working in clinics or working for pharmaceutical companies that work with disease pathways will have that intervention. And it's not just giving an intervention. If we take a drug, it's not just giving a drug to a patient and they will go through the progression of the disease with that drug, maybe in one healthcare setting. There are other interactions, including the environment, including the hospital, including places that give chemotherapy, if that happens to be the drug. There are different resources. There are different types of clinicians that can have an impact on the outcome of that individual. This makes discrete event simulation very, very, very important in my mind, allowing that representation of that actual clinical environment. First bullet point up there is it's a flexible modeling method. It represents complex behavior within and interactions between individuals, populations, and their environment. That is key. If we look back to the decision tree is very limited in terms of that. It cannot represent a continuous model without having unruly and long and big decision trees, and even then, in many cases, it presents an unrealistic picture of the disease progression and the activity of that intervention. Same thing with Markov models. Markov models, again, good for chronic recurrent situations, but the lack of memory and the nature of the cycles that prevent any interaction, if you will, between other cycles within that process does not give a true realistic picture of the healthcare scenario. Discrete event applications, you can see in the next paragraph that there are many articles. Operations research was the first area that discrete event simulation became popular. Over time, various publications have come out representing models in the biological field, process design, optimization, geographic allocation resources, even clinical trial design, and leading to policy evaluation. If you scan the literature, and by the way, the references that I have on the back will give you a good representation of what's out there, but there are many other articles coming out utilizing discrete event simulation that are comparing therapeutic interventions, and they provide good reading. And some may be in the disease area that you have an interest in. Articles are also coming out as it is being recommended as a preferred choice. Again, having greater flexibility in depicting the cost effectiveness related to prevention or therapeutic interventions for chronic disease. And that's a nice article, Article 18. If you have time, please read that. And it offers some benefits in that area. So what I'm going to do is explain to you a recent project using simulate and discrete event simulation that I've been working on, and I've been working on with the next presenter. But it's in the area of chronic wound care. Many of us think of wounds as, you get a wound and it heals within maybe a few days or maybe even a week, depending on what it is. There are wounds in particular that inflict people with diabetes, chronic heart conditions, and various other comorbidities that can be life-threatening. They can be very painful, and they exhaust a great deal of cost on the healthcare system. And the scope of this work is actually global. It is a project that I'm working on now that is expanding, and the next slide I will share with you the expansion of discrete event simulation and the reason why I'm using discrete event simulation. But in this patient disease pathway, an individual will present, in this case, with an uncomplicated leg ulcer. And they have different, there's different outcomes that can come about. Now, in the world of discrete event simulation, a patient would be considered an entity in this. Events that are part of discrete event simulation would be whether or not the ulcer heals, whether it becomes infected, whether the patient dies, whether the patient goes into the hospital for a severe infection, and so on. These are the major events that individuals for this particular disease, which is a chronic venous leg ulcer, have an opportunity to go into. Inherent within these different events are resource consumption. Resource consumption meaning dressings, meaning people, labor, doctors, transportation costs, and so on. And then again, leading to the possibility of death along this pathway. So this represents a pathway that is inherent, very naturalistic, that clinicians deal with. The other important feature to this is time. It's usually time to event. And these ulcers typically do not heal within a few weeks. In some cases, they do not heal for years. So we have to represent this process in a very naturalistic way based on these events with patients. One could also take this down to the wound level, where an individual has multiple types of wounds, and the wounds could be the entities. And depending on each wound, then events could transpire for each wound. So that's the flexibility of discrete event, where it would be very difficult to do that in a Markov model or in a simple decision tree. As I mentioned, the next evolution of this will be to place that process within a healthcare system. In this picture here, this actually represents the German system as it is set up now in Germany, where patients with chronic leg ulcers, 65% of those patients will start out with their general practitioner. 5% of them will continue care through their general practitioner. 60% will go to social care network, which is their community care. 90% of them will have a level of combination care with other providers. 10% will have care within another network where there are university comprehensive wound centers, leg ulcer centers, and then another 30% will go directly to non-hospital private specialists. And I can tell you each one of these pathways generates different outcomes. They have different processes of care for individuals with leg ulcers. And when I was talking about the interaction in models, this is a great example of interaction because these individuals typically do not stay in one care point. They could start out with a general practitioner where they get treatment, and then possibly after 2 or 3 weeks they go to another aspect of the healthcare system which provides further interaction in the attempt to heal these patients. So what we need to do, or what I'm doing in this process, is developing the discrete event model based on this pathway, and then taking the previous slide that shows you the disease pathway that is inherent in each one of these pathways, and forgive me, I'm probably a little confusing here, but that process, if the patient carries on from the general practitioner alone, and they go down to healing, quality of life, and economic outcomes, they follow the same path as going to healing, where they can be infected, they can go into the hospital, they can die, and so on. What we will do is we will compare those processes, number one, in terms of the ability to heal ulcers quickly, the ability to reduce the cost of those patients being treated by each care pathway. Now, again, that's interaction. That's very naturalistic. The Markov models, the decision trees, and other types of models have difficulties representing that care pathway. I can tell you with conversation with policymakers and providers, if you are a pharmaceutical company, or if you are one that wants to convince the payer or provider, or in some cases hospitals where I have encountered individuals that do research and they want to present a cost savings opportunity to their manager or to budget committees, representing that process in a real world, in a naturalistic way, is absolutely critical. Otherwise, it's not believable. And it makes it a more difficult time to convince people to take on that strategy or that drug or that process. So anyways, a little bit of information on that in terms of my work. I'm going to show you a real-world sample that I'm working on that represents the disease process and how we're generating cost. But I wanted to share with you some advantages of discrete event simulation, and in particular, the model that I just showed you is that the model would demonstrate healing progression. You can make a decision for best clinical pathway, whether it be the community, whether it be a clinic, whether it be a specialist, the time of reoccurrence for each patient, number of wounds separately, if you desired to do that. You can enter a large number of patient attributes, or what I should say entity attributes. You could consider their weight, you could consider their height, you could consider their wound size, you could consider the duration of that wound. And again, hopefully you can relate that disease to other types of diseases where biological parameters would be important in terms of the direction or the progression of that patient or that entity through the clinical process. So, and you can't do that in a Markov model. It's very difficult, but you simplistically can do that with discrete event simulation. The time to event, we can look at 100% healing, 75% healing, pain resolution. That comes down to the amount of time that the entity or the patient has spent in different clinical situations. In the model that we have built with Simulate, we can queue patients up. So in other words, we know that an individual with a certain type of an infection, they may be in hospital for 3 days, they might be in a hospital for 2 weeks, depending on the severity of that infection. We can queue that individual up, and we can continue to enter cost basically on that time to discharge, for example, which is very difficult to do with the other modeling techniques. Where I said previously that the Markov models, based on the Markov assumption, they do not have memory. The progression of that patient or that individual through the different health states, there may have been something that transpired 2 cycles before that definitely has an impact on outcome. Well, the previous cycle is pretty definite, and it tells that patient which direction or which cycle that they go to next, where discrete event models have memory. So they can remember what happened to that individual weeks, days before, and take that into consideration in the appropriate pathway moving forward. So individual life histories created by drawing randomly from distributions. You can use distributions in this model to select pathways based on particular events and outcomes that you have. Overall, generally speaking, discrete event simulation, it is a very good representation of clinical reality. And what I've been dealing with the past few years is the generation of observational research studies, outcome studies that are important for reimbursement of various pharmaceutical products and medical devices. In every encounter that I have with policymakers, especially reimbursement individuals, they want the best representation of reality that they face with, not necessarily just taking data from a randomized controlled trial, but can we take data from an observational study and produce a naturalistic way of simulation. And discrete event simulation is ideal for that. So, and as I said, it presents the course of disease naturally with few restrictions. I will say that one of the major limitations of DES is the information that we have from those clinical studies that are more naturalistic, that can fit into an ideal simulation model. But that's improving as time goes on. So, and in the respect to time as well, I'm going to go through this a bit quickly because I want to show you briefly the model that we have created, the simulation model. But it follows a natural concept of time. It has a clock, a simulation clock that can be generated to days, months, years, however you'd like to do it, no fixed cycles. It's quite a bit of flexibility in handling perspectives. So within that German pathway, if you will, you can see where there's different perspectives that we may want to look at. It could be a provider perspective overall, it's a payer perspective. And then the sensitivity analysis in terms of altering variables in there are easy. And the other big thing is permits transparency. Very easy to go back into the model and take a look at the variables and the data and the cost and the information that can be used for sensitivity analysis and the ultimate output. So, and I'm going to go down to the bottom here based on time, but in the economic evaluations, the DES model has a flexibility to accommodate a richer structure without making it unmanageable in size. The computing power is available now to run DES, so there's no reason why it shouldn't be used. And in fact, when you go in front of policymakers today, NICE, ICWIC, and other entities there, they're going to want to Depending on your problem, if you've got a chronic disease, they're going to want to know why you didn't use DES to do the simulation and represent the naturalistic aspect of the disease. So what I'm going to do is very briefly take you through a model that I have created with Simulate. And then right after this brief view of this, then Fiona is going to give you a little bit of instruction on building a model. So this particular model here was generated to take a look at a therapy called Vitegro in venous leg ulcers. A study was done that generated data for us. Other information from secondary sources and clinical trials was available that allowed us to populate this model with cost and so on. And what we can do with this is, for example, we want to take a look at the three possibilities that patient could go through. They could be treated by clinic alone, they could be treated with this drug, or they could be treated through the community, and again, both of these without the drug. And you can see up here we have the clock, so it's 365 days, which means that this is a year-long model. So what we're going to generate is within that naturalistic process, we're going to see how many patients end up with infected wounds, how many patients healed along that pathway, how many were hospitalized, bed days, and so on. My screen just went blank.
Okay. Well, you, so that you want to take control over Fiona?
Yep.
And you can run through your section just now. Are you okay there, Ron?
Yeah, I apologize. My screen just went blank, and I'm not sure why it did that. But if you could, please, Fiona.
Yep. Okay, so what I'm going to do is the model that Ron was showing you on the screen there is just to take you through how we can start to actually build that using discrete event simulation, particularly looking at the disease pathway for the chronic venous leg ulcer. And the way that I'm going to do this is use what we call state charts, and these allow us to look at the transition between different points in disease. So what we have in the disease pathway is for the leg ulcer is we have a cohort of patients that will all start with an uncomplicated wound, and from there they can progress. That disease will progress over time into different states, as we call them. So I would build up my different states that are part of this pathway that Ron went through earlier. So we had the uncomplicated wound. Patients their wound can get infected, so it becomes a clinical infection. They can also transition into having some sort of skin disorder. They can obviously heal. You know, there's a healing curve, so that they will heal over time. There is the probability that when we're looking at this model over the number of years that we're modelling this, that the patients may die. And also from the clinical infection, there's a chance that that patient might get severely worse, so they'll have an infection and that becomes much more severe. And again, we might want to put in another state here that it becomes so severe infected that, you know, we've in this model got a very ill state, which means, you know, they might contract other illnesses because of that infection. So there are all the disease states that Ron took you through earlier, and what we then want to do is link these up. So like we would do in any discrete event process, you know, from uncomplicated wound we can transition to clinical infection and back again. So I'm just going to link these up like so. And that is essentially our disease pathway that we've built. The next stage that we'd be wanting to think of is how the patients are transitioning into each of these different states. So, for instance, there is a probability over time that they're going to transition into some of these states. So they have a probability of death. And I'm just double-clicking on the arrow here as that denotes their transition. And so they have a chance every day, you know, there's a daily rate, or you might have a weekly rate. This model is set up for a daily rate. So their daily rate of death from an uncomplicated wound, or their death rate. I'm just going to input some of the data from model here. And again, there's a similar type thing for the skin disorder. So again, they have a chance per day of contracting some sort of skin disorder from having a wound. And again, the same application applies for the clinical infection. We have a chance per time unit. So again, I'm just going to put this in for you. So those are our probability transitions. We know that if a patient has a clinical infection or a skin disorder or a severe infection, the way that we've looked at this in the model is that there is a distribution of time, which Ron spoke to you about earlier, of how long they're likely to have that infection for. So this is, once they've had the clinical infection, we have an elapsed time for them to be able to move back into an uncomplicated state where their wound has become better. And what we use for that is just some distributions that I set up previously. So it's just using a distribution around the data that Ron provided us with. And the same goes for the skin disorder. So spend an elapsed time within that particular state. So again, it's the distribution. And we've used the same method for transitioning. So there's a distribution. So the longer that they spend within clinical infection, there is then an elapsed time that they might, if it's not been healed, that they'll then transition into a severe state. So the longer that they're in a clinical infected state, the more likely it is that they're going to become more infected if they've not yet been healed. And the same goes for the very ill state. And the last transition that we're looking for is our healed, our healing curve, if you like. So again, going back to Ron's data, I've just put this into a spreadsheet for you to see here as the heal curve, and this is over a year, and the probability of that wound healing over time. And what we can do is, again, double click on our arrow, and what we want to use this time is the percentage over time. So as time increases, we want to refer to that heal curve that I just showed you. So I'm going to refer to my spreadsheet there just to show that. And you see in the spreadsheet that it's by week, so up to 52 weeks. So I want to put in the week here. And what that's going to do is, as the model runs over time, is going to look at those different values that you see in the spreadsheet. So up to week 4, there's no patient has a chance of healing, and then from there, as the model progresses over time, that percentage chance of them healing increases, as you can see within this spreadsheet. So just to give you an idea, I'm just going to run that through for a year here. Oh, my apologies. What we want to start with as well is populate the model of our cohort. So I'm just going to put in 1,000 patients that are all going to start off in an uncomplicated state, and then we can see how that progresses over the year. I'm going to run that through, And at the end, what we can see, what we're left with is around 800 patients who have healed. We've had 30 deaths, and we've currently got around 123 patients who are still in an uncomplicated state. So this allows us to model the disease state very easily. As you can see, I've built that up. And what we then went on to do with the model, just to give you some more insight, is Ron was talking about costs in terms of bed days, resources. We can also start to link this disease model to what you may know as a typical discrete event process. So just very quickly, let's just look at the process of if a patient has a clinical infection, or they will go into hospital for a hospital stay, or if they have a skin disorder. So what we can do is, once a patient transitions into a particular state, we can automatically start to trigger arrivals in our discrete process here. So I'm just going to do that there. So what that means is that any patient that enters a clinical infection state is going to trigger an arrival here. And I'm going to do the same for skin disorder. And then what we want to do is that within this activity, so this would be our hospital stay, where we can then start to apply things like cost and resources to this. But I'm just going to simply show you here that the timing within that hospital stay we can put to dependent on until that patient is back in an uncomplicated state. They will be continued to have a hospital stay. And I'll just run this through just to show you that there.
While you're running that through, Fiona, I just have a quick question from one of our attendees. It's asking, can a patient be in two states at once, for example, a skin disorder and a clinical infection?
Yes, we can have what we call substates. So I'll just, for instance, we can drop on another state here, like so, and have that state encompass various different states, and they will then be automatically part of that other state, what that might be. So it could be that you have an overall state of being infected, but you might have multiple transitions as to that stage of infection. So we could, up at this top part of the model here, we could have an overall state, and we could model that there.
Okay.
Okay. So just running that through, looking at this, we can see there's been arrivals triggered. We've got a number of people who are currently having a hospital stay, and we've processed 55 patients. So it's looking at the number of people that have been clinically infected, have had a hospital stay, who are still in hospital, and we can then start to build up that process further.
Excellent. Okay, thanks for running us through the features there. I mean, there are some new features that we've got in for 2013, and as Fiona had mentioned, she is putting them in place with Ron as she's working through. Ron is unfortunately still offline. I think he's trying to come back on. I know a few of you have some questions for Ron in particular. So, I mean, we do have a note of those, and we'll try to get through to them. I just see Ron coming back on, so possibly if he's on within the next few minutes, then we will be able to put those to him. But if not, we just say, I mean, maybe Fiona, you could answer some of these questions, just really on because you've done a lot of work within health economics with Ron, and then obviously with some pharmaceutical companies as well, working through different transitions. And really, from Ron showed some earlier models, really with the Markov and the decision trees. And really this is a new way for to get to providers the different health economics models. So, I mean, what's the reaction like from people? You know, obviously, is it easy for them to pick it up, or what have you found taking simulation to them?
I think one of the key things about bringing simulation is the visual aspect of it, and it can make it a lot easier to take it out to providers for them to understand the patient pathways and how your modelling is working, whereas, you know, traditional methods, you know, such as the decision tree Ron mentioned, that they can get quite messy, quite hard to, you know, interpret. So it takes out that complicated element. So I would say that the visual aspect of it is a huge plus in this. Another thing is also the accuracy of it as well. We can start to model cleverly variation in demand and all those different things, as well as being able to model capacity. We can start to look at the actual capacity of their beds in terms of bed days very accurately, whereas in, again, traditional methods, it's not as accurate because we can't model the passing of time.
Yeah, I think that answers it there, Fiona. That's great. Unfortunately, can't get Ron back on. I can see he's trying to get on, but I know we're all getting through. So what we'll do is we'll get your questions answered and get back in out to Ron, and we'll look to schedule another possible workshop later in the year with Ron, because some really interesting points, and he's really been doing some great work from his point of view. So really want to get the opportunity to share that with you guys. So just leaves for me, I guess, to thank Ron, and I'll thank him when I speak to him again, and also Fiona for putting on the workshop today. We will, as I say, make a recording available and get the slides out, because Ron does have some information on those for you. And we will also get information out of the next workshop. I think we're looking at blood supply and simulation, how simulation is being used to improve that. And we'll get that out to you within probably within the next week and confirm who we've got speaking there. But again, thank you everyone. Apologies for the upset in Ron's connection there, but we'll get back to you when we can. Thanks. Have a good day.